Hello, I'm Dr. Donald Lloyd-Jones, Chair of the Committee of Scientific Sessions Programming for the American Heart Association and President-elect of the American Heart Association. I'm joined by Dr. Lisa Cooper, who's an internist and public health researcher from the Johns Hopkins Schools of Medicine and Public Health. Dr. Cooper, welcome.
Thank you.
And I'm also joined by Dr. Michelle Albert, who's a professor at the University of California, San Francisco, and president of the Association of Black Cardiologists. Dr. Albert, welcome.
Thank you, Don.
We all just had the remarkable experience of participating in a session on structural racism as a public health crisis here at AHA's Scientific Sessions 2020. And I think of all the things that have happened in this extraordinary year of 2020, we finally are recognizing the depth of health disparities that affect particularly the Black population in this country, but I think also, of course, many other communities of color and underserved communities across the United States. These disparities aren't new, of course, but I think COVID-19 has certainly brought them to the fore in this year. And as a response to that, AHA has done a number of things, including publishing a presidential advisory this past week on November 10th that lays out a framework for how the association will address these underlying issues of structural racism and how they affect social determinants of health, individual health processes, and overall create this public health crisis. In the session we heard today from Dr. David Williams and Dr. Lisa Cooper about some of the aspects of this public health crisis. And this is a thread that's really throughout all of this year's scientific sessions because of the importance of the theme. Dr. Albert, would you mind summarizing a little bit about how structural racism can lead to cardiovascular disease and to other aspects of public health?
Certainly, thank you, Don. Racism is categorized in several ways. One way is individual racism. The other is institutional or structural racism. Much of the research and the science around racism pertains to everyday racism and its relationship with cardiometabolic health. We certainly know that there's a positive relationship between everyday racism, and by everyday racism, we mean experiences at your job, experiences in medical, receiving medical care as examples, and biomarkers or risk factors for cardiovascular disease. We know that from a science perspective, that everyday racism is associated with higher levels of coronary calcium, is associated with higher levels of inflammation, which is an underlying premise for cardiovascular disease, including coronary disease. We know also that everyday racism is associated with poor sleep outcomes, higher blood pressure, especially diastolic blood pressure. And racism, especially structural racism, which pertains to policies and practices that are embedded in our systems and institutions that result in poor cardiovascular outcomes, are prevalent in our system. We also know that there's not much research actually related to structural racism, and there's great need for outcomes-related work, particularly in the cardiovascular arena, that looks at the impact of structural racism and also interventions for structural racism to mitigate risk in our patients, as well as in our workforce that I'm sure Dr. Cooper will address as she addressed earlier today. We know that structural racism is driven by economics, education, wealth, and the disproportionate relationship between those factors by race ethnicity, where Blacks historically have been at the worst intersections of health and these social factors, such as economics, higher rates of unemployment, higher rates of job loss, not having access to quality education, that affect the ability to achieve advantaged health outcomes in this country and worldwide for that matter. And all of that is rooted in a history of the slave trade, which has traversed the entire world, as a matter of fact, and is embedded in our systems of institutions that then relate to the poor outcomes that we see, not only from cardiovascular disease, but all diseases by race ethnicity.
Thanks so much, Dr. Albert. Dr. Cooper, pivoting to your talk, which again identified other aspects of this crisis, and particularly importantly, I would say, addressed issues of the health workforce. Could you tell us a little bit about your perspectives?
Certainly. So, as Dr. Albert mentioned, we have these disparities in access to education, and so many things that actually impact people's ability to achieve the goals that they set out for themselves. So really, when we think about the fact that those factors actually have an impact on who gets into medical school, who gets into science careers, and who has the luxury of, for example, pursuing a research career as opposed to going into clinical practice where they can generate more income to pay off debts. So, when we think about that, it's no surprise that even though in the US population, we have African Americans, for example, representing about 13% of the US population, but only 6% of medical students, or 4% of medical faculty. So we have underrepresentation among health professionals, among people from communities of color. That includes African Americans, Hispanics, as well as Native Americans, American Indians. We have underrepresentation among leadership. So, we have people who are in charge of setting policies and practices within our healthcare delivery organizations and in our C-suites. And, despite an organization perhaps providing care to a very large ethnic minority patient population, we see that most organizations have among their executive leadership less than 10% representation by African Americans, Hispanics, and Native American or Indigenous Americans. So we have lack of structural diversity in the health professions. And this starts all the way actually before medical school, because again, opportunities to attend college and to pursue degrees in science. We see it along the academic trajectory. So, for example, there have been studies, as I discussed in my presentation, showing that as you go along the academic trajectory from junior faculty up to senior faculty, you see a decreasing representation of women and men of color as you progress up the ladder. So we see that going on. A lot of that is in large part due to these structural inequities that have led to lack of financial opportunities, the need to pay off debts. And then we have the sort of interpersonal exposures to discrimination within our delivery systems and within our educational institutions. So the diversity climate, for example, is not as friendly to people of color. There are so many reports of faculty and students of color reporting that they've been discriminated against or harassed within settings, that they don't have adequate opportunities to network with people who have positions of influence that might actually provide them with opportunities, professional opportunities, lack of mentorship with regard to specific social issues. So, and in some cases, actually lack of professional mentorship. So just being socialized into what the norms and mores are of the profession and what's required. So you have these things going on at multiple levels. And, it sounds like it's just a dire situation, which it is a crisis in many ways, but I think that we have heard that there are interventions that are in place, and there are certainly signs of hope, and we know that there are effective ways to overcome these. What we do need is the will and really sort of the infrastructure and the funding and the support for these programs.
If I could, I want to just take a little bit of a deeper dive on one aspect of what you're talking about. All of it's important, of course, but let me flip the perspective for a second. Why does it matter to a patient that their provider, their clinician looks like them or comes from a background similar to them?
Yeah, well, I know I've been involved. Of course, I've led some research many years ago showing that when patients shared racial or ethnic background with their provider, that they were more involved in decision making, and that the conversation tended to be more balanced. It wasn't only about the medical or the biomedical issue; it was also about sort of psychosocial and emotional issues, and also about issues outside of healthcare that might be impacting their ability to be healthy. So, and it's not that surprising that when we have people who look more like us, that we tend to be more comfortable with people like that. Now, that's not to say that everybody needs to have a race concordant provider, but we know that it's important in certain situations for people to be able to identify on a cultural and a sort of a social level. And we also know that having more diversity in the profession is actually something that enhances the quality of experience for everyone. So that's really, many people have actually argued that the importance of diversity is not only about, making things better for people of color, but it's actually an excellence imperative, because really having more diverse members of our workforce and of our scientific workforce leads to more creativity and innovation and excellence, leads to better sort of educational experiences for our students, and then also leads to better patient and population outcomes, better access to care, because many physicians of color and other health professionals of color do go back to their communities that tend to be underserved to provide that care.
Well, I want to thank you both so much for joining us. We can barely scratch the surface of understanding structural racism as a public health crisis. I want to urge our viewers to go see that session, because I think it was really important. And there's another video that we're shooting that talks about some of the solutions, and those we had a chance to get to in depth in the session as well. So really want to urge people to go see that and start a conversation and start thinking about these issues more broadly. Again, thank you both so much for joining us today. And I hope that you're all enjoying scientific sessions and looking for the threads that are addressing structural racism and some of the potential solutions that we can use to address it. Thanks so much.
Thank you for having us.
John.